Hello friends, today I'm going to talk about the ANS and pain. It is told that pain is the toughest enemy of human being, but I feel pain is our friend because pain is the first person to protect us since birth. It is a protection. We have a natural pain management system in our body. That's why in the sports, players are getting injured, again they're getting up and playing. Are they not getting pain? In the war front, soldiers are getting injured by the bullets, but still they are fighting. Are they not getting pain? So we are having a very good pain management system in our body that is protecting us. And pain also stimulates healing. But sometimes that friend becomes a disturbance. That's our chronic pain. We can see the knee pain, back pain. We know where the friend is there, but it is disturbing us. On the other hand, sometimes pain is hidden. All the investigations, everything is normal, still patient is getting pain. Even after the trauma, the pain is developing from this area. In our body, autonomic nervous system also working in a hidden way, where many times the pain is associated with this autonomic nervous system and it has become hidden. So that's why to understand this unknown pain, we have to thoroughly understand the autonomic nervous system. Let's go back to the first MBBS and thoroughly understand the basics of the autonomic nervous system, which will help us to search the hidden pain. Autonomic nervous system is a part of the nervous system which regulates the involuntary activities of our body. It is also called visceral nervous system because the whole body, viscera, except the skeletal muscles, everything is controlled by the autonomic nervous system. So like central nervous system, it is also made up of the afferent and efferent pathway. Visceral afferent pathway is same like the somatic afferent pathway. We'll see afterwards how the nerves are there in the dorsal ganglion. But visceral efferent pathway is different from the somatic efferent pathway, which is coming from the lateral horn, whereas somatic efferent is coming from the anterior horn. So somatic efferent fibers pass directly from the CNS to skeletal muscles, but autonomic visceral efferent fibers do not pass directly to the visceral effector organ from the CNS. So that is the most important difference between ANS and CNS. CNS directly supplying to the muscle, but ANS to supply to the organ, there must be having a ganglion in between the spinal cord and the organ. That is the basic difference between the ANS and CNS. They first relay the autonomic ganglion outside the CNS, and then the postganglionic fibers supply the effector organs. The only exception is adrenal medulla, because adrenal medulla itself is a collection of the postganglionic neuron. So we can say this efferent pathway of ANS is made up of the two neurons. One is preganglionic, one is postganglionic. So afferent pathway is made up of the pseudounipolar neurons, same like our somatic afferent, which is residing inside the dorsal root ganglion. So whether the pain is coming from the autonomic nervous system, whether the pain is coming from the organs, or pain is coming from the muscle, the nerve cell is there in the dorsal root ganglion. That's a whole world trying to control the pain attacking the dorsal root ganglion, whether it is autonomic pain, whether it is somatic pain. If we stop the dorsal root ganglion to work, you can control the pain. Autonomic nervous system can be divided into three divisions: sympathetic, parasympathetic, enteric nervous system. But basically, we'll first study the sympathetic and parasympathetic. Now, the most important line I'm going to show you that all the efferent peripheral fibers belong to the ANS, except those to the skeletal muscles. Whatever going from the spinal cord to the whole body, it is ANS, except skeletal muscles. So that's a very, very important thing, because many chronic pain can be correlated with ANS at anywhere in our body associated with any kind of trauma. So they are unseen. So we have to think that autonomic nervous system is working in almost every point in our body except skeletal muscles. Now we should know what is the sympathetic and parasympathetic outflow. The preganglionic sympathetic fibers that arise from the lateral horn cell of the thoracic and the upper lumbar segments, we can say the T1 to L2, that's why it is called thoracolumbar outflow. And the preganglionic parasympathetic fibers arise from the general visceral efferent. I will explain why it is called general visceral efferent. And so they are the nuclei of the brainstem and from the S2, S3, S4 sacral segments of the spinal cord. That's why it is called combination of the cranial and sacral outflow. So we can see in this part, the right side, the whole body system you can see. Left side, whole body organ system is there. But sympathetic is controlled the whole body only from T1 to L2. Whereas parasympathetic control is done by this upper part and the lower part, where the cranial and the sacral outflow. We'll come in detail about this. Before that, you should know the difference between the general visceral efferent and the spatial visceral efferent. Here we'll see the whole body organs, they are actually coming into the category of general visceral efferent, except those parts which are developed from the branchial arch. So they are coming into the category, special category. So there the viscera are called the spatial visceral efferent. So when the spinal cord is developing, that time you can see it is divided into alar lamina and the basal lamina. In the basal lamina, this is the column which is called the general somatic efferent. So this is actually supplying the muscles, and this is called the general visceral efferent. So this is the part which is forming the lateral horn and supplying the all sympathetic of this whole organ system of our body, general visceral part. Where in the posterior part, where the alar lamina, which is forming the posterior horn, where we can see the general somatic afferent and general visceral afferent. So there we'll see the pseudounipolar neurons, which is having the central process and the peripheral process. The central process is attached to the posterior horn, whereas the peripheral process attached to the either organ or the muscles or any part of the body. That's why today the dorsal root ganglion is the most important part to control the pain today, whether the pain is coming from autonomic or from somatic. Now if you see when the spinal cord is developing and slowly going up, and at the medulla if you see, so that is opening like a book. You can see the half part, you can see this whole part here, this side, here's the fourth ventricle. This is called rhombic leaf, from where the cerebellum is developed. So in between the cerebellum and the brainstem, we are getting the fourth ventricle. So now the brainstem, where it was actually the continuation of the spinal cord, it opens like a book. So the relation between the sensory rootlets and the motor rootlets here in the spinal cord is the anteroposterior, where here it will be lateral medial. So that's why whenever you will see the cranial nerves coming out from the brainstem, the motor root will be always medial, sensory root will be always lateral. Just see about the facial and the trigeminal, which is the most important nerves in the head face. Facial nerve, thick motor root will be medial, thin sensory root will be lateral, whereas trigeminal just opposite, thin motor root will be medial and the thick sensory root will be lateral. Now coming to this blue part, you can see that spatial visceral efferent. So this is a column which is appearing same like in the lateral horn, here in the medulla, here in the brainstem you can say. So that is supplying the areas which are developed from the branchial arch. So they are called the spatial visceral efferent. So they are not there in the spinal cord. So that is coming in between this general visceral efferent and the general somatic efferent is a new column. In the same way, spatial visceral afferent, you can see it is also appearing in between the general somatic afferent and general visceral afferent. Okay. Preganglionic parasympathetic fibers, they arise from the general visceral efferent nuclei of the brainstem and S2, S3, S4 sacral segments of the spinal cord, which are called the craniosacral outflow, which is supplying the whole organ system in the body. Now sympathetic parasympathetic ganglia. Sympathetic ganglia are connected to each other and form two beaded chains which are situated closer to the spinal cord on the anterolateral part of the vertebral body. So sympathetic ganglions actually closer to the spinal cord, whereas the parasympathetic ganglions is closer to the organ. So we can say the preganglionic sympathetic fibers are shorter like the postganglionic parasympathetic fibers. Preganglionic sympathetic fiber and the postganglionic parasympathetic fiber, whereas the preganglionic parasympathetic fiber are longer like postganglionic sympathetic fiber. Preganglionic parasympathetic fibers are longer, same like your postganglionic sympathetic fibers. In that way, we can see, so these are the parasympathetic ganglions which are closer to the organ, where the sympathetic ganglions are closer to the spinal cord. So why they are called parasympathetic ganglion? So parasympathetic relay will be there. Why they are called sympathetic ganglion? The sympathetic relay will be there, the preganglionic and the postganglionic fibers. They're relaying in that ganglion. In that way, they are named. Now we can see the comparison of the effects of the sympathetic and the parasympathetic functions is very commonly we know, we have studied in our MBBS period, but the most important thing you have to see, the limbs have no parasympathetic supply. So here you can see this everywhere, sympathetic is working, but parasympathetic has no work. So parasympathetic is working in the other way with the sympathetic inhibition, sympathetic activation. Sympathetic inhibition is working like parasympathetic in the limbs. That's why there is no parasympathetic. So maximum chance for complex regional pain syndrome, CRPS, is very, very common in the limbs. That is why, because the counteracting parasympathetic function is not there, it is totally sympathetic. So any kind of trauma, any kind of injury may cause the sympathetic overactivity in that limbs, which is causing the CRPS 1 or CRPS 2. But we should know what is the significance of the sympathetic or parasympathetic systems in our body. We know sympathetic system work for the fight or flight response. How you will explain this? If somebody is trying to hit you, what you will do? Either you have to fight or you have to flight. As per your capability, you can fight or you can flight. But for both the things, what is needed? We need power. If we don't have power, neither you will be able to fight nor you will be able to flight. So that's why if you have a power, the power is restored. Who has restored the power? The restoration of the power is done by the parasympathetic system, whereas the exhaustion of the power will be done by the sympathetic system. Because you have power, with that power you can fight or you can flight. So that is the protection system. But nowadays, philosophically, if you see, people are utilizing their power unnecessarily. People are wasting their power unnecessarily, fighting with flighting. So that is giving them disturbance. People are suffering with blood pressures, people are suffering with diabetes, insomnia, indigestion, so many complications they're suffering because they're unnecessarily wasting their power, fighting with people, just they're disturbed. So in that way, if we know how to make you stress-free, how to make you cool down, so you can have the control over the sympathetic. And this sadhu, sant, wisdom people, they're advising us to reduce the stress by different ways with meditation, pranayama, music therapy, or mind destruction. Basically, they are trying to stimulate parasympathetic. If you know how to stimulate parasympathetic, how to cool down yourself, automatically, unnecessarily energy wastage will not be there. You will be more healthiest. Now we will learn about the sympathetic efferent pathways. Preganglionic sympathetic fibers, they arise in the lateral gray column of T1 to L2. So they emerge as myelinated axon through the corresponding anterior primous ramus and pass via the white rami communicants into the ganglia of the sympathetic tongue. We'll come to this point. Before that, this myelinated, unmyelinated, very common confusion there in many people. So I will show you one slide. So if you see the swan cell actually covering the nerves, when it is covering in a multiple layers, so that is actually myelinated. We are mainly getting in the multiple neuron, we are mainly getting in the motor neurons, whereas when swan cell, one swan cell is enclosing multiple neurons, so that is actually called unmyelinated. But actually they are not bare nerves. It is not possible because nerves are like electric wire. They have to have some insulation. It cannot be totally unmyelinated. Okay, there the single swan cell okay, engulfing several unmyelinated nerves. So that is called unmyelinated. So I will give you a simple example. You can come to know that why a newborn baby has no control of the bladder bubble function, but after a few years the control automatically come. How? Because in this age still the spinal cord myelination is not completed. All the nerves, many nerves are open. Okay, so that's why short circuit happens. The function of the bladder bubble is automatically happening as per reflex. By sympathetic, bladder is filling. By parasympathetic, it is clearing. So in that way, the same thing is happening pathologically when the spinal cord injury will be there. So there will be no heart center control. So once in this age, normally the myelination is done, then the heart central control is coming. So we can control the bladder bubble as per our wish through the pudendal nerve. So that is the concept between the myelination and unmyelination. Now come to the sympathetic efferent pathway. They emerges as the myelinated action. So you can see here in the lateral horn. So this is the cell body. They're coming. So they are the efferent nerves. In the same way from the anterior horn, the nerves will come out, motor cells which are supplying to the muscles. And the gray column were the sympathetic efferent. They are coming out, and this is the preganglionic fiber in the ganglion. They are synapsing in the postganglionic. So postganglionic, we can say this is the gray ramus. So this is the white ramus and this is gray ramus in a short. Sometimes it can synapse in the ganglion. It may pass through the ganglion and coming to form another ganglion, what we used to see in the paravertebral cilia ganglion. So that is, and from there the postganglionic are coming. In that way, it will make different circuit, different chain, which is very, very tough to understand how it is made. So last white ramus is the L2 and the first white ramus is the T1. So it's T1 to L2, the whole body is supplied, whether it is in the leg or in the head face, everything is in between this T1 to L2. So after L2, there is no white ramus. Everything is the gray ramus. That's why L2 is the most important thing. I will come to you regarding this part, regarding the pain correlation about this. So now if you see how the postganglionic fibers they are forming. So once the preganglionic fibers reaches the paravertebral ganglia, the different way the postganglionic fibers are coming out. So the postganglionic fibers, they are also again non-myelinated. So arising from the ganglion cells and rejoining the spinal nerves as the gray ramus communicants and distributed through its branches to the blood vessels, sweat glands, erectus pili, everywhere. I already told you, everywhere in the body, the ANS, except the muscles, which are the CNS, which are supplied by the anterior horn cell, except everywhere the ANS. So some fibers ascend to the sympathetic trunk, synapse with the cervical sympathetic ganglion, forming the superior, middle, inferior. I will come in detail. Some fibers leaving the ganglion without synapsing. So there's the splanchnic nerves, they're piercing the diaphragm, then coming to the celiac trunk and forming the celiac ganglion or other paravertebral ganglions. Some fibers pass to the suprarrenal glands where they're synapsing with the cells within the medulla. Because already I told you, medulla is totally different. It is just like a postganglionic fibers arising from there. So it is a ganglia actually. Some fibers descend to synapse with the lumbar sympathetic. In that way, different ganglia are there throughout the vertebral column. 3 in the cervical, 11 in the thoracic, 4 in the lumbar, 4 in the sacral. So we will see separately. So these are the ganglion from which the postganglionic fibers are coming, and they are making the plexus with the postganglionic parasympathetic fibers and making the autonomic plexuses. So if we see the cervical sympathetic chain, there we will see the cervical part of the sympathetic chain extends from the base of the skull to the neck of the first rib. 3 large ganglions we used to see, superior, middle, inferior, but actually if you see here, they are believed to be formed during the development by fusion of the smaller segmental ganglion. So all ganglions are there, but they fuse. So from the first to fourth, they fuse to make superior ganglion. 5th, 6th, they are making middle, and inferior with 7, 8 and T1. Ultimately, it is formed the big star shaped ganglion, that is we know the stellate ganglion. In that way, these 3 were the superior mainly concerned about the head face, and the middle inferior concerned about the thoracic and chest. So cervical ganglion, they receive the preganglionic fibers from T1 and T2 spinal. This is the most important line. So that's why for everything, for every sympathetic mediated pain, whenever you are suspecting, don't miss to block the stellate. If you give the stellate, then somehow you are covering all sympathetic overactivity of the head face. Okay. Now coming to the thoracic sympathetic chain, usually consists of 11 because we have seen T1 already fused with the stellate. So they all are connected with the wide gray rami communicants to the thoracic spinal nerves. First 5 thoracic nerves, T1 to T4, actually give postganglionic fibers to the heart, lung, esophagus. So if you are thinking for any kind of sympathetic mediated pain coming from the thorax, so either you have to give T2, T3 or continuous high thoracic epidural. So that will be used to control the pain, sympathetic mediated, and it will simultaneously, if you give epidural, it will help for the somatic also. And from then the T5 to T12, we know these are the splanchnic nerves. So these are arising from the thoracic. They are passing through the sympathetic ganglions, but not synapsing there. They are piercing the diaphragm, then they are coming out from the diaphragm into the abdomen and around the celiac trunk, supramesenteric. So they are forming the ganglion, celiac trunk, celiac ganglion. So celiac ganglion is actually the sympathetic ganglion. From there, the postganglionic fibers are coming out and making the plexus with the branches of the vagus and forming the celiac plexus. Though they are very close by, but actually that's the difference between the celiac ganglion and celiac plexus. So where you can block either by bilaterally giving the splanchnic nerves at T10, T11, T12, or you are giving transaortic celiac plexus coming in front of the celiac trunk at the level of celiac trunk, at the level of L1 to block the upper abdominal pain, because this will supply so up to the vagus, where that is the junction between the right 2/3 and left 1/3 of the transverse colon, because that is the junction between the midgut and the hindgut, which is blood supply. The midgut supplied by the supramesenteric, hindgut supplied by the inframesenteric. So you have to think, if anything, any pain coming from the descending colon, so then you have to target the splanchnic nerves, S2, S3, S4, suprahypogastric. If the pain is coming from the ascending colon, transverse colon, right part, so you have to think, you have to target the celiac trunk, celiac plexus, because it is supplied by the vagus. You can see here postganglionic fibers from celiac ganglion mix with the branches of the left and the right vagus nerves to form the celiac plexus, supramesenteric plexus on abdominal aorta to supply till the junction between the right 2/3 and the left 1/3 of the transverse colon. What is the developmental background? You now understood. So lumbar sympathetic chain, there are 4 lumbar sympathetic ganglions, but only upper 2 ganglia receive the white rami. So that's why for any lower limb pain, pelvic vascular disease, or any kind of CRPs in the lower limb, you cannot leave this L2. Because usually we target for lumbar sympathetic chain L2, L3, L4. L2 should not be missed, because that is the last white rami. After that, everything is gray rami. I don't know how the body is totally making this very complex circuit to make this plexus. So L2 you cannot mix, because if you are leaving L2, if you are giving L3, L4, some people they're telling you can give an L5 also, but actually you should not miss L2, because if you miss L2, if you are missing the white rami, because after that all gray ramis are connected with this white rami, so I cannot mix this white rami. And if you see, visceral branches of the lumbar splanchnic pass down to form the plexus in front of L5S1 vertebra called superior hypogastric plexus. So theoretically, when superior hypogastric plexus are formed, is all through this nerve only. So if we are giving lumbar sympathetic L2, L3, L4, it should work anatomically, theoretically, for pelvic organs sympathetic overactivity. But usually we don't give. Why? Because if you are selectively giving superior hypogastric, we are leaving those nerves, those who are going for the lower limbs. Okay, lower limbs, abdomen, abdominal wall, you can leave, that is not needed. In the same way, sacral sympathetic, this fiber is coming down and joining with the S2, S3, S4, you can see that in the lower picture. They are forming this ganglions, where the last ganglion is the ganglion impar. For any kind of pelvic pain, any kind of particularly CA rectum, we should give both suprahypogastric as well as ganglion impart. Okay, so any kind of sympathetic pain is there in the perineal pain. See, many times patients are getting pain after post-pile surgery, post-anal surgery. In those cases, we should target this ganglion impart, which is the last sympathetic ganglion in front of the sacrococcygeal level. So we know how to give it. So in those cases, we should target the ganglion impart to block the sacral sympathetic chain. So all these sympathetic preganglionic fibers, they're coming and forming the celiac ganglion, supramesenteric ganglion, inframesenteric ganglion. So you can see this inframesenteric ganglion also is called hypogastric ganglion. So supramesenteric ganglion, this is also a ganglion. This is not paired, this is unpaired, whereas celiac ganglion is a paired on the both side of the celiac. So this is celiac, this is supramesenteric. This celiac, it is actually vertebral level is L1, supramesenteric L2. There is nothing at L3. At L4 level, at that L4 level, we are getting inframesenteric. So in that way, these two are basically here the plexus which is forming. They are supplying up to the right 2/3 of the junction between the right 2/3 and the left 1/3 of transverse colon, up to that level. So when it is coming to the inferior mesenteric, then slowly they are getting more closer to the hypogastric ganglions, forming the superior hypogastric. So we are coming at the level of L5, because at the level of L4-5, this abdominal aorta bifurcates. So at the level of L5, when you are targeting the superior hypogastric, you are actually closer to the left and the right common iliac, not the abdominal aorta. Okay, when you are giving lumbar sympathetic, you are closer to the abdominal aorta. When you are giving superior hypogastric, you are closer to the common iliac, where left side is more important than right side, because the aorta is coming in the left side. Major plexus, they're all making this network around the artery, not around the vein. So that's why major plexus are there on the left side. If you're thinking for diagnostic for suprahypogastric, better to target on the left side, not on the right side. After that, when you're thinking for giving this neurolysis, then you can target both sides. Now, after completing the sympathetic efferent, now we have to know about the parasympathetic efferent. Okay, so parasympathetic efferent, we know some part is there in the cranial and some part is there in the sacral. So the cranial outflow, though we know that in the brain stem, 10 cranial nerves are there. Out of 12 cranial nerves, 1 and 2, they are coming from the brain in front. But from 3 to 12, they're all attached to the brain stem. Out of that, all the cranial nerves are coming from the ventral side of the brain stem, whereas except 4, which is coming from the dorsal side. Anyway, we are concerned about the 4 cranial nerves which are related with the parasympathetic efferent pathway. There's the 3rd, 7th, 9th, and 10th. These 4 cranial nerves which are concerned with the cranial outflow of parasympathetic. Okay, now we will see and how out of all these nerves, though we cannot see 5th, but 5th, the trigeminal is so important, how trigeminal is helping, or these nerves are taking help of trigeminal to finish their pathway to reach the organ. So trigeminal is not only motor, not only sensory, it is also autonomic, that we will come to know here. And the rest of the part from the neck to right 2/3, junction between the right 2/3 and left 1/3, that is the vagus. So we can see this all preganglionic fibers, they will terminate into the parasympathetic ganglion. See, we are not telling these are the sympathetic ganglion, these are parasympathetic, because we have seen in our earlier slides the parasympathetic relay is happening. Ciliary ganglion, pterygopalatine, submandibular, otic, they're all parasympathetic because they are parasympathetic preganglionic, parasympathetic postganglionic, that relay is happening. Sympathetic relay is not happening here. For head face, all sympathetic this relay happened in the superior cervical ganglion, middle, inferior. So T1, T2, that is preganglionic, and from there superior cervical, from head face totally supplied by the superior cervical, middle, inferior supplying the thorax and chest. So now postganglionic fibers coming through the ophthalmic, they're taking the help of the trigeminal, the branches of the trigeminal, ophthalmic, for ophthalmic nerves, the short ciliary nerves, maxillary nerves, mandibular nerve, we will see one by one in every level. So if you see the ciliary ganglion, it is there in the orbit. So these are four most important ganglions. Parasympathetic ganglion, they are not sympathetic ganglion. Sympathetic fibers are passing there, somatic passing there, but relay is happening of parasympathetic. That's why they are called parasympathetic ganglion. They are not called sympathetic ganglion. Whereas you see stellate, it is called sympathetic ganglion. It is not parasympathetic ganglion. So here ciliary ganglion, you see how the fibers are there, parasympathetic fibers. Preganglionic third, postganglionic fifth. Preganglionic third from the adenoid nucleus, preganglionic, and from after that postganglionic, it is taking the help of the branches of ophthalmic division or the trigeminal. But if you see the sympathetic, it is coming from the T1. T1, preganglionic, T1, T2, superior cervical, from their postganglionic, taking the help of the artery and reaching, it is passing through the ganglion. It is not synapsing. That's why this ganglion is called parasympathetic ganglion. This is called sympathetic ganglion. This is the difference. That's why this will be the common for every head face. Now see, pterygopalatine, sphenopalatine, preganglionic, seven cranial nerve, postganglionic, branches of maxillary, the 5 branches, the lacrimal, orbital, nasal, then gutta-palatine, lesser palatine, pharyngeal. So if you see the cluster headache, so that time these fibers are responsible. So they are not the sensory fibers, because maxillary basically is a sensory, but these are the autonomic fibers of the trigeminal, which are helping this preganglionic fibers to complete their autonomic service. But see the preganglionic of the sympathetic, it is same like your ciliary, T1, T2, superior cervical, from there. So for everything, for if we think, because many times atypical facial pain, we are targeting sphenopalatine. The sphenopalatine bilateral I can target, but I cannot target bilateral stellate, because that is a risk, because that may affect the heart. Only some special conditions are there, like your pulmonary embolism or uncontrolled ventricular tachycardia. I got a call from the ICU when there was a resistant case. Patient was not, they were even giving lots of defibrillation. Patient's heart rate is not controlled. Then I had a call for that. I have given bilateral stellate. It helped a lot. So that is very, very selective cases where you can give bilateral, but it is very risky. You have to be very, very cautious. That's why here I can give bilateral pterygopalatine, but I cannot give bilateral stellate. But any kind of sympathetic mediated pain, head face, you should always target stellate. Now see, what about the otic ganglion? Here, the preganglionic fibers coming from the 9th, because this is concerned with the parotid secretions, but postganglionic through the 5th cranial, again auriculotemporal. One syndrome is the Frey syndrome. So there, this hypersensitivity of this auriculotemporal nerve. So that sympathetic overactivity, ultimately I have to target the stellate only, because sympathetic fibers are coming preganglionic again from T1, T2, postganglionic superior cervical. So for head face, anything, anywhere, whether it is a cancer pain, whether it is any other unknown pain, when you think it may be sympathetic mediated, so let's give a diagnostic block at the level of stellate, but don't give bilateral. Now coming from the submandibular, again you will see the same thing. It is the preganglionic 7th, but postganglionic again 5th. Lingual. So we can see in the head face, so important nerve is the trigeminal. It is not only sensory, it is not only motor, it is also helping in autonomic to complete this journey of the autonomic supply to the organs, because the preganglionics are different cranial nerves, postganglionic all are trigeminal. But sympathetic, it is same everywhere. See, again T1, T2, superior cervical. So whether it is submandibular, whether it is otic, whether it is sphenopalatine, whether it is ciliary, everywhere the sympathetic target is your stellate. So be careful. You have to be always think about, but the difference is if there is the pain or the sympathetic mediated pain in the upper limb, you have to add T2, T3, because head face T2, T3 is not going. Upper limb T2, T3 has to be added. I will come to this point afterwards. So now I will tell about the parasympathetic efferent for the sacral. After completing the cranial, now we'll see what about the sacral. So there, preganglionic fibers arising from the lateral gray horn from the S2, S3, S4 sacral segments. So we know spinal cord ends at the level of L1. So at that level, you can imagine the sympathetic of the T10, T11 up to L2, but simultaneously after that, the parasympathetic fibers also coming from the S2, S3, S4, that spinal segment in the same area, the lateral horn gradient. So they are coming down, but they are not coming out from there. They are totally coming down and coming out through the sacral foramen. Then they are synapsing with the sympathetic chain, which are coming from the lower lumbar segments and forming the superior hypogastric plexus and supplying the pelvic organ. Okay. So this autonomic fibers, the efferent fibers, after forming ganglion, they are forming the plexus. So large collection of afferent and efferent autonomic fibers and their associated ganglion form the autonomic plexus is in thoracic, abdomen, pelvis. At the thoracic level, we will get cardiac plexus, pulmonary plexus, esophageal plexus. Abdomen level, celiac, superior inframesenteric, aortic. In pelvic, superior infrahypogastric. In that way, we can see this tremendous network, how it is supplying the organs, the whole top to bottom in our whole body. After knowing about the efferent fibers, now it is time to know about the afferent, from where the pain is coming. If the pain is coming from the muscles, easily we can tell. But if the pain is coming from appendix, how it is coming? In every case, whether it is autonomic afferent or somatic afferent, the cell body is there in the dorsal root ganglion. You can see this, the pseudounipolar neuron, the central process is the peripheral process, and from the heart or stomach. So everywhere, ultimately, dorsal root ganglion is the most important thing. Whole world is focusing dorsal root ganglion, because whether the pain is autonomic, whether the pain is somatic, every pain can be controlled, the targeting the dorsal root ganglion. Many times what we are doing dorsal root ganglion RF. Okay, so you have to be very, very cautious, because dorsal root ganglion RF means we are so close to the motor nerve. That's why we are not doing CRF, we are doing PRF, pulse radio frequency. But if you see trigeminal nerve, even if it is motor, we are doing CRF. So very surprising. This is sensory ganglion, we are going for the PRF, but that is a motor nerve, we are going for CRF. Why? Because here the nerve is so close. These are the sensory rootlets, these are the motor rootlets, they are forming at this level. The intervertebral foramen is there. So when you are putting the needle, you are so close to the root, so you may burn the root, you may affect the motor nerve. That's why whenever you are doing dorsal ganglion RF for the cervical level, lumbar level, you have to be very, very cautious. You cannot choose CRF, you have to choose PRF, pulse radio frequency, not the conventional radio frequency. Otherwise the motor nerve can be affected. But when you think for the trigeminal nerve, CRF, so what is happening, even if the mandibular nerve is motor nerve, even if you are burning, but we are not getting much problem in the chewing and other things, because the other side is supporting, and the structures closer to the brain, they have a bilateral supply. And TM joint cannot work alone, they are working together. So in this way, even if you are doing CRF of the trigeminal nerve, we are not getting much problem in the motor activity of the jaw. So this is the dorsal root ganglion, where all the nerves, why this bulge? Because the cell bodies of this pseudounipolar neurons, which is having central process attached to the posterior horn, peripheral process attached to the organ. Okay, or here the sensory nerves attached to the muscles and other part of the body. So impulse, which are the impulse carrying out? All visceral reflexes, then sensation of hunger, thirst, anything. And on top of that, most important is the visceral pain. So once the autonomic afferent enter the spinal cord or the brain, they travel with the somatic nerves, because here we are not only getting the autonomic afferent, we are getting somatic afferent also. And that is why that is causing the misinterpretation of the brain and causing the Rayford pain. We'll come to that point. So the nerve endings of the autonomic fibers are not activated by that's the difference between the somatic afferent and the autonomic afferent. The organs not getting pain by heat, cut, touch, but they get activated by the stretch, by lack of oxygen. See your bladder, when it is filled, you are getting a wish. If it is too much filled, then you are getting pain. So by stretching the organs, they are getting pain, not by pricking, cutting, they don't get pain. Or lack of oxygen, they will get pain. But if you see here, any head face, how all the nerves, what I was telling here in the cell bodies of the afferent nerve, of ANS are located in the dorsal ganglion or sensory ganglion of the cranial nerve. So this, all the nerves, trigeminal, facial, glossopharyngeal, vagus, they all have sensory ganglion because you can see here, because their sensory nerves cannot be inside the brain and spinal cord. That is the rule. That's why dorsal ganglion is outside the spinal cord. Trigeminal ganglion is outside the brain. They're actually same. Trigeminal ganglion, dorsal ganglion, same. If you divide our body at the level of the C1, at the level of the neck, a part of the neck, so the head face, the all sensory is coming through the trigeminal mainly, okay, and the whole body coming through the spinal nerves. So where the dorsal ganglion is there. So in the trigeminal ganglion also we are getting this pseudonuclear neuron. In the central process attached to the pons, peripheral process attached to the head face, and the same in the spinal nerve. The central process attached to the spinal cord, peripheral process attached to the organs or muscles or everywhere. So that's why this sensory ganglion, it is inside the vertebral canal but outside the spinal cord. Trigeminal ganglion inside the cranium but outside the brain. In that way they are same. But this trigeminal ganglion, facial, glossopharyngeal, vagus, they all have sensory ganglion outside the brain. If you see this nerve supply of the tongue, you will come to know so complicated, so many nerves are supplying the tongue. Very good example. If you see the tongue, very commonly asked in the MBBS people, the nerve supply of the tongue. So we have to discuss first the motor nerves, motor supply, sensory supply, and the special sense. General sense and special sense, they are coming to the sensory. Special sense is the test. General sense, pain, touch, temperature. Motor, all the muscles of the tongue, extrinsic, intrinsic, supplied by the hypoglossal, except the palatoglossal, which is supplied by the cranial accessory through pharyngeal plexus, where the vagus nerve is there. And the general sense, anterior 2/3, we can divide the tongue into anterior 2/3, posterior 1/3, and posterior most. So anterior 2/3, general sense, pain, touch, temperature going through the lingual trigeminal. Posterior 1/3 supplied by the glossopharyngeal, general sense, and posterior most by the vagus interlaryngeal. But if you think about the special sense test, anterior 2/3 is carried by the chorda tympani through facial, posterior 1/3 by again glossopharyngeal, and posterior most by the interlaryngeal. So the posterior 1/3 and posterior most, their glossopharyngeal, interlaryngeal, they are both common. They are carrying not only general sense, they are carrying special sense also. So definitely they have their ganglion because sensory nerves cannot be inside the brain. They have to be outside the brain. So any pain here you are getting in the pain. So if you know this nerve supply, it will help you tremendously to particularly focus the nerve, and always keep it in your mind for head face, anything you have to target the stellate, because from there sympathetic supply is coming. Nowhere sympathetic coming. You are not getting sympathetic from the cervical level. They are all coming from the T1, T2, T3. So stellate is the most important ganglion for any sympathetic overactivity in the head face. You have to give a diagnostic block. Okay. So now coming to the visceral pain and the referred pain. Very interesting thing, because of the dorsal ganglion is carrying both somatic if afferent as well as autonomic afferent. Visceral pain usually dull, boring, poorly localized due to the stimulation of the large number of fibers. And somatic pain is very sharp because it is precise, well localized. So what is referred pain? The visceral pain is frequently referred to the skin areas, we all know dermatomes, so that are innervated by the same segment of the spinal cord as the disease viscera. So pain will be felt at the site remote from the source of the origin, as in the dorsal ganglion having the both somatic and the visceral afferent fibers. So what is the brain is percepting? When the nerves fiber from the viscus enter into the spinal cord, somatic nerves of the same dermatome together get stimulated, and they together stimulate the second order neuron. For that, the cerebral cortex fails to distinguish the misinterpretation. As the pain sensation doesn't come from the viscera, brain interprets that information is coming from the skin. So in that way, this misinterpretation is causing this referred pain. So we should know what are the different referred pain are there. Heart, from the heart, we are getting the pain in the left pericardium, anginal pain, okay, left arm, forearm, gallbladder, the tip of the right shoulder, spleen, tip of the left shoulder, diaphragm, tip of the shoulders, then appendix, testes, ovary, they are all supplied. The T10, that's why at the level of umbilicus they used to get pain. So in this way you can see how the organs and the referred pain sites are connected. So this will help you to imagine or correlate about the patient's different pain and how to target the sympathetic to find out whether the pain is sympathetic mediated or not. Now I will show you one example of the pelvic organ, how it is supplied by the sympathetic, parasympathetic, somatic. Then you will come to know same thing is happening for the other pelvic organs. So bladder, one of the most important organ. So it's sympathetic supplied by coming from the last 4-5 segments, T10 to L2. So they are coming then from the ganglion. It is supplying the bladder wall, sympathetic supply bladder wall, that is relaxing the bladder wall, detrusor muscles, and that is constricting the internal sphincter. Whereas parasympathetic coming from S2, S3, S4, that is contracting the bladder wall but relaxing the sphincter. That is happening in the newborn baby, what I told you earlier, that as the higher control is not there, higher control, now we can see here the pudendal. This is the green, S2, S3, S4, this pudendal is coming. So that is controlled through the higher center at the external sphincter. So as long as higher center is not connected, when the myelination is complete, your higher central control is not developed, we don't have any control over here. But if there is any trauma, any spinal cord injuries above this T10 level, so this will give you same kind of problem in the newborn baby, when the bladder will work as per the reflex only, but it will, your higher center, your control will not be there. Or if there is injury at this level, okay, so L1, L2, T12, 11 at the conus medullaris level, so then this autonomic system will be totally damaged. So that time it is called autonomous bladder. If the injury is above this, it is automatic bladder, automatically filled and cleared by the reflex. But when the injury will be there in that, which will damage the autonomic nerves, so then it will be autonomous, it will be totally flaccid, dribbling of the water will be there. So we have to put the catheter. So these are the anatomical explanation of the automatic bladder, autonomous bladder. So in the same way, all the pelvic organs are supplied, and if you see anatomically, why I was telling, if I give lumbar sympathetic, it should work for the superior hypogastric, because the same nerves are coming to supply the pelvic organs. But usually we don't give, you are targeting specifically on the superior hypogastric, so that the fibers which are coming to the abdominal wall, which are coming to the abdominal organ, which are coming to the lower limb, so we can avoid those fibers, so we can only target the superior hypogastric. Otherwise, theoretically, anatomically, if I give lumbar sympathetic, definitely it should work for the pelvic organs. Now coming for the autonomic innervation of the upper and lower limb. Already I was discussing, for the upper limb, preganglionic fibers coming from the T2 to T8, they're coming up and they are ending at the cervical sympathetic ganglions, and postganglionic fibers pass through the brachial plexus and supplying the upper limb arteries. So any kind of sympathetic overactivity in the upper limb, any CRPS, any peripheral vascular disease, in those cases you have to target stellate as well as T2, T3. Keep it in your mind. You cannot leave T2, T3. For head face, you can leave T2, T3. But for upper limb, you cannot leave T2, T3. So, for example, if you are planning to give stellate, so better you target at C7 under fluoroscopy, what we do. But if you are targeting with ultrasound at the level of C6, if your drug is not covering this T2, T3 separately, you have to give the T2, T3 under fluoroscopy guidance. But if you are giving stellate ganglion, you are not that much competent to give T2, T3, just to see whether your dye spread is coming below or not. If the dye spread is coming below, so then with little more volume, you can cover up the T2, T3 in those patients. After that, you can plan to give T2, T3 separately if the patient is getting good results with the neurolysis of alcohol or radiofrequency. In the same way, the lower limb preganglionic fibers arising from the T10 to L2 spinal segments, and they are supplying the lower limb. So any kind of CRPS, any kind of peripheral vascular disease, or any kind of sympathetic overactivity is coming, particularly the burning pain. Many times patients are complaining of burning pain. Burning pain is a sign of sympathetic. It is not the somatic. Okay, so patients complaining of burning pain, so you have to target the lumbar sympathetic for diagnostic. So now we can see so many cases are there which are actually connected with the ANS, whether it is CRPS1, CRPS2, cluster headache. We have seen sphenopalatine, Frey syndrome, this auriculotemporal bulges, abdominal pain. Even some studies they are telling for irritable bowel syndrome, it can work if you get a good results with the diagnostic block of the celiac. Then cancer pain. Okay, so particularly if you see the cancer pain, pelvic cancer pain, then if you are targeting superior hypogastric, you should target simultaneously with the ganglion impaired, both the things, so that superior hypogastric, inferior hypogastric, ganglion impaired, everything can be covered. I got some unusual cases, like one lady around about 59 years old, she had donated her kidney to her husband. After donation, she continuously getting pain, developed pain in the back, in the buttock, in the thighs. Her MRI is normal. Almost 1.5 years she is suffering, treated by different doctors. Everywhere they are not getting clue why the pain has come. So then she was referred to me by a physician. What I did, I have given diagnostic lumbar sympathetic L2, L3, L4. Again, I am telling, don't miss L2 because that is the last white tremor. I have given diagnostic lumbar sympathetic. After one dose, she got very good relief, more than 80% relief. She got her day-to-day activity tremendously improved. She has given a feedback video also to me. Then after 2-3 months, then I have done alcohol neurolysis with RF. And another case, I got one, he was a farmer. He is suffering with head pain, the neck pain, shoulder pain. He had a history of electric shock on the hand, on right hand. But when he came to me after different treatments, his brother brought me. So his brother was telling that we have shown to many doctors. His brother was telling we have shown to many doctors, but we are not getting the clue why the pain is coming. So then I asked how it started, because he had a electric shock on the right hand. So then I thought, let's try to give the stylet on the right side first, because I cannot give, though now the problem is on the both side, but I cannot give bilateral stylet. So I have given first in one-sided stylet on the right side, and then he came back. I told him after a few days I will give the second side, but after 15 days he got very good relief. The brother came back with him and asked me to go for the left side. So in diagnostic only he got a very good relief. Now almost 3-4 months gone. He's doing well. He told if he is getting uneasy, then I will go for the neurolysis. So in that way, my main intention, you understand the autonomic nervous system, nerve circuit in such a way, whole body, whenever you are not able to find out the pain, how you can correlate your ANS to the sympathetic mediated pain. And simultaneously, if you understand the autonomic nervous system for yourself, so that will tremendously help you to control your stress. That is the most important thing, which we used to give advice to the patient. Don't take stress. But I used to say doctors has a right to take stress, because we know how to control ANS. So if you have a control on your ANS, you are the happiest and healthiest person in this world. Thank you.